And hello, everyone. Um, so here are my conflicts. COPD, as we all know, is the third leading cause of death globally. And in our department, a few years ago, we started communicating more with patients, and we tried to find what are the patients' priorities around research gaps and evidence gaps in COPD. And one of the issues that was highlighted was that COPD has a significant treatment burden, so it is associated with a lot of side effects, and patients consider it a priority to develop more personalized treatments for COPD. Inhaled corticosteroids have been one of the mainstay treatments for COPD for many years because they reduce exacerbations, as we know, they improve pulmonary function, and they can improve quality of life as well. However, we do know that they are also associated with a significant increase in the risk of pneumonia, and this was the first paper that showed this data back in 2009 from TORCH. And TORCH suggested an increase by 7%, increased risk by 7% over a period of 3 years, but it included patients without that severe COPD. So in patients that we normally treat with ICS, the risk may be even better. Here we see some interesting data from the Salford lung study, and we can see that the risk of death in pneumonia, in severe pneumonia leading to hospitalization, is 4 times higher than the risk of death in a severe COPD exacerbation, and that's important. So the question is how we can balance the benefits with the potential risks of inhaled corticosteroids. And of course, we all know that inhaled corticosteroids target eosinophilic inflammation in the airways, and because blood eosinophils are well correlated with sputum eosinophils, we now use blood eosinophils to guide the administration of inhaled corticosteroids for COPD. And this is one of the first studies that show it, a post-hoc analysis of 3 AstraZeneca studies. A few years ago, I found this very, very interesting study. In this study, instead of using high versus low eosinophils to decide if we are giving or not giving inhaled steroids, the investigators did something else. They give increasing doses of inhaled steroids until blood eosinophils are suppressed, and they showed that this is an effective strategy. What does that tell us? It tells us that blood eosinophils suppress in response to inhaled corticosteroids. They are a responsive biomarker. That's important because it tells us that perhaps if we measure blood eosinophils while patients are receiving inhaled steroids, they may not be as accurate. So from this starting point, we defined 3 blood eosinophil biomarkers. Blood eosinophil off steroids, so when patients are not receiving any steroids, blood eosinophils measured on ICS, and blood eosinophil count change during treatment. And we have been trying to find out if they have differences and which is the best biomarker for assessing treatment response to inhaled corticosteroids. So first, we gained access to the data from the ISOLDI trial, which is a very old COPD trial from the 1990s that compared fluticasone propionate versus placebo and for 3 years. And it has a very important characteristic for us. It had a running period of 8 weeks while inhaled corticosteroids were not allowed, and it had a lot of measurements of blood eosinophil count. So if we take different time points, patients had blood eosinophils measured, a lot of patients had blood eosinophils measured while they were taking inhaled steroids and while they were not taking inhaled steroids. So we could define our biomarkers well. So we had a good study population with blood eosinophils on, off, and blood eosinophil change during treatment. And we reanalyzed the data from the ISOLDI trial to see which of these biomarkers work better. An important limitation of Isolde is that we did not have baseline exacerbation data, and that is, well, nowadays we do want to have this in our analysis. We can see here that when we reanalyze the data, that we found that inhaled corticosteroids appear to decrease the rate of exacerbations independently of blood eosinophil count, even if, independently of whether they were measured on or off inhaled corticosteroids. But we see that we had some very interesting findings around blood eosinophil chains. And we see that in people with negative blood eosinophil chains, so suppressed eosinophils while they were receiving inhaled steroids, we see treatment benefit, and that was around 40% of the participants. In 40% of participants where eosinophils did not change, there was no benefit, really. And in 20% of the participants where eosinophils increased on treatment, these patients had risk. So they had a significantly high risk of exacerbations. When we looked at pulmonary function, we found a similar signal. So here we look at the blood eosinophil counts measured off steroids. And we can see that we have the anticipated progression. So the higher the blood eosinophils, the better response to inhaled corticosteroids. But let's see what happens in blood eosinophil count on inhaled steroids. So here we have the patients stratified according to the blood eosinophils that were measured while they were receiving steroids. And we can see the opposite direction of association. So lower blood eosinophils on inhaled steroids suggested better treatment response. Why? Perhaps because the people who were up here, high eosinophils off steroids, if they responded, they suppressed their eosinophils and went there. And that is further supported by the findings of the blood eosinophil count change analysis. And again, blood eosinophil count suppression, it means better lung function with inhaled steroids. Blood eosinophil count increase was associated with faster ICS decline with inhaled steroids. But Isolde had some limitations. It was a 1990s trial. The definitions of exacerbations were not that rigorous at the time. The population was heterogeneous. It was not the indication that we have for inhaled steroids nowadays, because at the time we didn't even have tiotropium. It was only then developed. So we replicated our analysis in the FLAME trial. FLAME trial compared LABA-LAMA versus LABA-ICS, and we selected it specifically again because it had a run-in period of 2 weeks where inhaled steroids were not permitted. And that's important for us because after the run-in period we had blood eosinophils off steroids, and before, in a good percentage of the population, we had blood eosinophils on. Sorry, after we had off and before we had on. And our primary outcome was the rate of moderate or severe exacerbations, and we found that among patients with lower blood eosinophil count off steroids, LABA and LAMA combination was clearly superior to LABA and ICS in preventing exacerbations. The association between blood eosinophil count on ICS and treatment response did not reach statistical significance, but we see relatively similar trajectories, and there were some limitations that we discuss there. And again, we see that blood eosinophil count change was, again, consistently a promising biomarker. Here is where we discuss the limitations. So the problem with blood eosinophil count on inhaled steroids that we didn't foresee before getting access to data from FLAME is that the measurement of blood eosinophil counts at baseline coincided with spirometry with bronchodilation, and in preparation for the spirometry, people were advised not to get any inhaled steroids for at least 2 days. So our blood eosinophil count on inhaled steroids is a bit weaker than we would like normally. They have already started changing back to the blood eosinophil count of ICS, we believe. And here we see the time to first moderate or severe exacerbation. Here I also wanted to highlight specifically in the back chains that the change in the balance between LABA-LAMA and LABA-ICS was at minus 170 cells per cubic microliter, and that's important. So suppression of at least 170 cells per cubic microliter in blood eosinophil count was associated with better treatment response to inhaled steroids. So now here we split our population into people who suppressed by at least 170 or people who did not suppress in response to inhaled steroids. And we looked at time to first moderate or severe exacerbation. And we can see that in the participants with suppressed eosinophils, LABA and ICS has a clear benefit in delaying the time to first exacerbation compared to LABA-LAMA. And here we can see the opposite trajectory in people that did not suppress. And this also supports the idea that blood eosinophil change is a very strong biomarker. And now some even more interesting results. Here we see that time to first pneumonia analyzed according to blood eosinophil count change again. And we see that in people with suppressed eosinophils who respond to inhaled steroids, there is no additional risk of pneumonia, and that's important. The additional risk of pneumonia appears to be with patients who do not suppress their eosinophils, so the non-responders. So there is a genuine imbalance. Some patients gain all the benefits and some patients appear to get the side effects, and that's something to keep in mind. And here, just another subgroup analysis really, looking at the rate of moderate and severe exacerbations among patients with suppressed eosinophils versus not suppressed eosinophils. And we can see again a clear difference in the treatment effects. So if we had to summarize the data by now, we can say that blood eosinophil count change appears to be an accurate biomarker of treatment response to inhaled steroids. We can say that higher blood eosinophils measured while patients are receiving inhaled or systemic steroids are less strongly associated with better treatment response to inhaled steroids compared to blood eosinophil count off treatment. And that we need more accurate biomarkers to guide inhaled corticosteroids withdrawal, because when we try to withdraw inhaled steroids, we now use blood eosinophils immediately before the treatment decision, so on inhaled steroids. And we can see here the guidelines of the ERS that suggest that if the eosinophil count, I have to say, on inhaled steroids here is high, we continue ICS. If they are low, we stop. But it seems that our data, although preliminary yet, appear to suggest a different approach. And again, I want to be clear that we need further validation before considering this for clinical practice. But for ICS discontinuation, it may be important to try it in people, especially in people with significant infection burden, for example, independently of the blood eosinophil count while they are on steroids. We can do a trial of ICS withdrawal, and 2 weeks is sufficient for getting the real eosinophil count of steroids trajectory, and then make treatment decision based on the blood eosinophil count of steroids. Now, after we finished this analysis with eosinophils and inhaled corticosteroids response, we wanted to see as well what happens with smoking, because there were data suggesting that people who are current smokers may have limited treatment response to inhaled steroids. So we took the previous analysis exactly from FLAME, and we split the groups into current smokers and ex-smokers. And we can see in the ex-smokers groups the same trajectories both for blood eosinophil off inhaled steroids and blood eosinophil change on treatment. Exactly like the main analysis. But when we look at the current smokers, we see consistently worse outcomes with LABA and ICS compared to LABA and LAMA. So that suggests that indeed In this population, people who are current smokers may not respond well to inhaled corticosteroids. And we went on and looked at subgroups of patients that, based on our previous analysis, should have responded really well to inhaled corticosteroids. And we can see very clear groups here. So current smokers, in groups with high eosinophils, LABA-LAMA is still superior to LABA and ICS, while in people who are ex-smokers, we see the anticipated better response to inhaled corticosteroids for people who have high eosinophils or eosinophil suppression. So, in reality, what are we saying? We are saying that the association between inhaled steroids treatment and treatment response is very complex, and we need more data. So, to address this data gap, we have started the ICS RECODE, which is an individual participant data meta-analysis, and we want to gather data from a lot of clinical trials evaluating inhaled corticosteroids versus non-inhaled corticosteroids, and find predictors of treatment response to ICS. So we brought together a group, a multidisciplinary group of experts. We brought on board patient representatives, and we set up a collaboration with the pharmaceutical companies that have done most of the trials looking at inhaled corticosteroids. And we are very happy that we have managed to get patient-level data from 20 clinical trials with over 50,000 participants. The plan is now to do an IPD meta-analysis, which is a cutting-edge methodology where we will reanalyze data from the original trials to address our new question, and specifically the question around what predicts treatment response to inhaled corticosteroids. So at the first stage, we'll do a single univariable level analysis, but we also plan to develop prediction models of treatment response. And in addition, the ICS RECODE dataset, we believe it's a great resource that we hope, in collaboration with our partners, with our pharma and patient partners, to further interrogate and address additional important research questions. So if we had to summarize and take home messages, it seems that inhaled corticosteroids do offer significant benefits, but for a very specific group of patients that we have not fully defined yet. They do have side effects, and there is some evidence suggesting that people who are not getting benefits may get a lot of side effects burden. We need precision medicine intervention, and we hope that we'll find that extra evidence to support precision medicine through the ICS RECODE population. Thank you.